Hey everyone and welcome. If you're a medical trainee, I know that managing heart failure with reduced ejection fraction, or HFrEF, can feel like a real puzzle. Well, today we're going to build a super clear framework for it. We're going to focus on the 4 pillars of modern therapy that will absolutely transform how you approach these patients. Let's jump in.
So here's our game plan. First, we'll tackle the why, that vicious cycle that drives HFrEF. Then we'll build the 4 pillars of life-saving therapy piece by piece. After that, we'll look at some add-on meds, talk about what to do when drugs aren't enough, and finally, we'll put it all together into a simple algorithm you can actually use on the wards.
All right, first things first. We have to understand the pathophysiology. To really get a grip on how our treatments work, we first have to understand the problem we're trying to solve. It's all about the why before the how.
So, what exactly is HFrEF? Well, the official guideline definition is pretty straightforward. It's a left ventricular ejection fraction of 40% or less. That number, which you'll get from an echocardiogram, is our critical starting point for everything that follows.
See, HFrEF is a progressive disease, and it's driven by this nasty feedback loop. It all starts with some kind of injury that reduces the heart's output. The body, trying to help, flips on its emergency systems, the renin-angiotensin-aldosterone system, or RAS, and the sympathetic nervous system. Now, in the short term, this helps, but long term, it's a disaster. It leads to fluid retention and clamps down on blood vessels. This extra strain makes the ventricle change shape in a bad way. We call that remodeling, which makes its function even worse, and the cycle just keeps going. Our entire treatment strategy is designed to smash this cycle.
And that brings us right to the heart of our talk today, how we actually break that cycle. This is the foundation of what we call guideline-directed medical therapy, or GDMT. These are the 4 classes of drugs that are proven to save lives.
And here they are. I want you to think of these as the 4 legs of a table that's holding up your patient. You've got RAS inhibition, and we'll see why an ARNI is preferred. You've got an evidence-based beta blocker, then a mineralocorticoid receptor antagonist, or MRA, and finally, the newest player, an SGLT2 inhibitor. These 4 are your non-negotiable starting points.
Okay, let's break them down. Pillar number 1, RAS inhibition. Remember that overactive RAS pathway from the vicious cycle we just talked about? Well, these drugs go right after it. They strike at the very core of the problem.
Now, here's where the modern approach really shines. We used to rely on ACE inhibitors or ARBs, and they're good. They block the harmful angiotensin II. But the newer class, ARNIs, they do that, plus they boost the body's own helpful natriuretic peptides. It's like a 2-for-1 deal. The huge PARADIGM-HF trial showed that an ARNI cut mortality by 20% compared to a standard ACE inhibitor. That's a massive deal, and it's why for most patients, we go with an ARNI now.
Okay, I need everyone to listen to this. This is a critical safety point. If you're switching a patient from an ACE inhibitor to an ARNI, you must have a 36-hour washout period in between. This is absolutely essential to prevent angioedema, which is a scary, life-threatening swelling. This is one of those high-yield facts you just have to burn into your brain.
All right, on to pillar 2. So just like we hit the RAS pathway, we now need to calm down the other half of the problem, that overactive sympathetic nervous system, the body's fight-or-flight response. That's where beta blockers come in. They basically tell the heart to chill out, slowing it down, reducing its workload, and over time, they can actually help reverse that harmful remodel.
Now, key point here, not all beta blockers are created equal in HFrEF. Only these 3 on the slide have been proven to save lives: carvedilol, metoprolol succinate, make sure it's the succinate, and bisoprolol. The mantra you need to remember is start low and go slow. You titrate up every couple of weeks. And one more crucial safety tip, never ever start a beta blocker on a patient who's acutely decompensated and full of fluid.
Moving on to pillar 3, MRAs. Think of drugs like spironolactone and eplerenone. These guys target the very end of that RAS cascade, a hormone called aldosterone, which promotes scarring and fluid retention in the heart. And honestly, despite being proven lifesavers, these drugs are probably the most underutilized of the 4 pillars.
So why are they underused? Well, the main reason is because they can cause high potassium levels, or hyperkalemia, especially in patients with kidney problems. So here's your clinical checkpoint. Before you start an MRA, you have to check the kidney function. Make sure that eGFR is at least 30. And then you've got to keep a close eye on their potassium levels after you start it.
And that brings us to our 4th and newest pillar, the SGLT2 inhibitors. These drugs have been a total game changer. They started out as diabetes medications, but they've just shown these incredible benefits in reducing hospitalizations and cardiovascular death for HFrEF patients.
And here's the truly mind-blowing part highlighted right here from the DAPA-HF trial.
Their benefit has absolutely nothing to do with blood sugar. Let that sink in. These drugs work just as well in HFrEF patients who don't have diabetes as they do in those who do. This finding is what cemented their place as a foundational therapy for the heart.
Okay, so you've done it. You've got your patient started on the 4 pillars. But what happens if they're still short of breath? What if they're still feeling congested? What other tools do we have? Well, this brings us to our next section, add-on therapies. These are the medications we pull out to manage specific symptoms or for certain patient groups, but only after our foundation of the 4 pillars is solidly in place.
So what are these add-ons? Well, for fluid overload, the congestion, we use loop diuretics, like furosemide. They help patients feel better, but they don't save lives like the pillars do. Then there's ivermectin. This is for a very specific patient, someone whose heart rate is still above 70, even though they're on the highest dose of beta blocker they can handle. And finally, and this is important, for Black patients with persistent severe symptoms, the combo of hydralazine and isosorbide dinitrate actually has a proven mortality benefit.
But you know, even with all these medications, some patients just have stubbornly poor heart function. And that's when we have to start thinking, maybe drugs just aren't going to be enough.
The magic number that should make you pause and think about device therapy is an LVEF of 35% or less. But, and this is a big but, this is only after the patient has been on our best medical therapy for at least 3 months. We have to give the medicines a real chance to work their magic first.
So when we talk about devices, there are really 2 main ones to know. First is the implantable cardioverter defibrillator, or ICD. Think of this as a safety net. Its whole job is to shock the heart out of a deadly rhythm and prevent sudden cardiac death. Then there's cardiac resynchronization therapy, or CRT. This is for patients who also have a really wide QRS on their EKG. It's basically a fancy pacemaker that helps the heart's walls squeeze and sync again, which can really improve symptoms.
Okay, deep breath. We have covered a lot of ground. So now, let's pull all of these pieces together into one simple, actionable game plan.
Here it is. The big paradigm shift in modern HFrEF management is this. We now start all 4 pillars as early as we possibly can, often together or in very quick succession. The old way of thinking, start one drug, max it out, then start the next, that's gone. We titrate all 4 up at the same time, as the patient tolerates it. We use diuretics as needed for symptoms, and then after 3 months on this new, optimized regimen, we check that LVEF again to see if they might need a device.
And that's it. That's the modern approach to HFrEF. It's proactive, it's foundational, and it's built on these 4 life-saving pillars. So the question I want to leave you with is this. The very next time you see a patient with HFrEF, how are you going to build these 4 pillars for them?